to start. So, hi there. Welcome to the next session in our Confronting the Drug War series. I'm Katie Simon, and I'm a leadership team member of National Survivors Union, the United States National Drug Users Union, and executive staff in two of its affiliate groups on the ground. Most importantly, for today's purposes, I'm a member of the COVID-19 and Substance Use Data Collaborative, whose policy group has been creating this multi-part roundtable series, Confronting the Drug War, drug user-oriented harm reduction and drug policy, for this past year. We've held sessions on safe consumption sites, safe supply, narco-feminism, journalism in the drug war, and deconstructing addiction as a brain disease model. As usual, this series is sponsored by the UCLA Center for Social Medicine, the Yale Program in Addiction Medicine, National Survivors Union, Program D35 in Drugs, Society, and Social Sciences at EHES, and the Drug Policy Alliance. Today, we're starting a few webinars we will hold on reactionary backlash against harm reduction and progressive drug policy by specifically discussing drug decriminalization amidst this sort of backlash. I'll be moderating a session in which I'm joined by the Sex Worker Advocate Coalition's Chibundo Egwatu from Washington, D.C., the Sidewalk Project's Soma Snake Oil from Los Angeles, the Measure 110 Oversight and Accountability Council's Morgan Godwin from Oregon, Oregon criminal defense attorney and documentary filmmaker David Menschel, and finally, José Quiroz, executive director of Amidst from Portugal. And I would love if each of you could go around and give us a quick intro with your name, your pronouns, your affiliation, and your past and current experiences with drug decrim, just a little bit about your journey and your motivators for this work. And I'm just going to start with who's first on my screen. So Chibundo.
Morning, everybody. Is it morning? No, it's afternoon. Good afternoon, everybody. My name is Chibundo Egwatu. I work for a harm reduction agency called HIPS in Washington, D.C., in the Northeast. I work in their advocacy department and the coordinator of that department. I'm also the coordinator of the Sex Worker Advocates Coalition. And HIPS is currently co-leading a campaign called Decrim Poverty DC, which is the campaign to decriminalize personal use of substances and to create a 24/7 harm reduction infrastructure that includes safe consumption in DC. My approach to decrim, of course, is partially due to the work that I do, working with both people who have a background or current experience in sex work and or drug use. But also before this, my entire organizing trajectory has always been abolitionist. And of course, the drug war is a huge part of the struggle for abolition in the United States.
Beautiful. Thank you so much. Morgan, you're next on my screen.
Yeah, hi. My name is Morgan Godwin, and I was appointed by the Oregon Health Authority to our Drug Decriminalization Measure 110 Oversight and Accountability Council. That is the community council that oversees the implementation of our drug decriminalization and the reappropriation of funds, our cannabis tax revenue that goes to fund substance use services. I'm also a drug policy researcher with the Action Lab at Northeastern University and a research consultant. I've been involved on various Measure 110 process and outcome evaluations. I come to this work. Initially, I was a volunteer on the Yes on Measure 110 campaign because I have direct experience with criminalization, specifically receiving multiple drug possession felonies and a substantial amount of jail time here in Oregon. And then I sort of translated that lived experience, combined it with professional expertise, and now find myself deeply involved in Oregon's drug decriminalization.
Thank you so much, Morgan. David.
Hi, I'm David Menschel. I'm president of Vital Projects Fund, a foundation that gives grants to organizations seeking to reform the criminal justice system. Our main focus is on reforming how the system treats people who commit violent crimes, but we also do a small amount of drug policy funding, mainly around issues that other foundations are frequently reluctant to fund. Things like safe injection sites, drug decriminalization, and drug-induced homicide laws. One example is we were one of the first foundations to fund Safe House in Philadelphia. I guess we've also been funding Drug Policy Alliance in one way or another for I don't know, a decade or more now.
And let's see who's next on my screen. Thank you so much for that, David. Soma.
Thanks, Katie. My name is Soma Snake Oil. I am the executive director and co-founder of the Sidewalk Project. And our headquarters are in Los Angeles. We are a lived experience. I think I just said that. We're a lived experience harm reduction organization. We work primarily in Skid Row and in MacArthur Park. I am a lived experience person. My lived experiences with drug use and sex work and houselessness and raising a child as a single mother. I was investigated by DCFS because of my work and happily did not lose my child, who now works for me today, which is very exciting. My work in this space is, I'm very interested in the feminization of poverty, of gender-based violence, of gender-specific harm reduction services. And for the past year, I ran an illegal OPC in Skid Row, specifically for women, with a big emphasis on working with sex workers as well. We just had to shut down the program, but we hope to open again. And my organizing experience is kind of within sex worker and drug use space around decriminalization. And we fought for and won SB 233, which decriminalized condoms in the state of California, and also created immunity for sex workers to be able to report violent crimes without getting arrested themselves. Thanks for having me.
You so much, Soma. And last but certainly not least, Jose, if you could tell us a little about yourself.
Hi there. Good afternoon, and thank you very much for the invitation. So I'm coming and I'm speaking from Porto, Portugal. So I am the executive director of a Portuguese NGO, and we mostly work in harm reduction field. So we are very concerned, in developing programs that are community-based. We are concerned to integrate peers and people using drugs and sex workers in our programs. And because we are concerned with the quality of our response and the impact on the communities. So we have opened now in the last year a drug consumption room also in Porto. So it's the first one, being running in Porto. And one of them, I would say, most, one of my favorite actions, let's put it like that, it was a collective action with some drug users 10 years ago, more than 10 years ago, where I co-helped them, to create a drug users association in Portugal. So it's the first one of the few in Europe. And I'm so proud that, they get totally empowered, and now they are, big critics of my own work. So they criticize me a lot, and I'm very proud of that, actually.
I love it. So yet another somewhat introductory question, which I'd like the entire panel to take. So what does decriminalization mean in your state and your nation's context? So basically, can you tell us what decriminalization means and what it doesn't mean where you are and how it came to be? And actually, wait, obviously that only applies to a few of our panelists. So maybe we can start with Morgan, go on to Jose, and end with Chibundo. So Morgan, would you like to start us off?
Yeah, so in Oregon, decriminalization was achieved through Measure 110, which brought all the penalties down one notch. So what had been misdemeanors became a new civil violation, so a non-criminal offense. So people can no longer get arrested for drug possession. The limits are set quite low. It is 1 gram or less of heroin or fentanyl and 2 grams or less of methamphetamine and cocaine. can under no circumstance result in someone's arrest. People are cited, given a ticket with $100 fine that can be waived if they do a behavioral health assessment within 45 days. All services offered are entirely voluntary and non-coercive. And simultaneously wrapped into the measure, it took our cannabis tax revenue and placed it into a fund that the council I sit on then did the grant determinations, and we injected $300 million into organ substance use services, low barrier treatment, harm reduction, peer services, housing, and supported employment. And so that is the crux of what decriminalization means here. Previous felony levels are now misdemeanor, but arrests have plummeted. It's now pushing almost 10,000 people have been spared arrest since this went into effect in February 2021.
And now, Jose?
Well, it's very difficult to answer in a very short way, 20 years of decriminalization in Portugal. But I can say that, in 1997, the drug phenomenon was considered the first social problem to our Portuguese society in Portugal. And there was, a huge nuisance in public space. So the decision makers they felt obliged because, of the dramatic situation, even in media, to present some new strategies to deal with that. And so they invited an expert group in 1999 to design a new model, the so-called Portuguese model. And basically, I can say that, besides the common, things that are associated to a drug model, like, prevention, law enforcement, treatment, and social research, and what Portugal, has designed as a new thing to our country was to create dissuasion as a factor and harm reduction. So dissuasion and harm reduction were the new, let's say, strategy introduced in our crime model. Another thing that, if you ask me, was that, very effective? Do you have success with this? I can say yes, if you look to the metrics. So if you look, to HIV outbreaks, we can see a huge decrease, So for example, I can give you some data. In 1999, we had 104 HIV new cases per million people. Nowadays, we are, around 4 HIV new cases per million people. So that's quite very effective, I think. Another thing was, when you look to the prisons and to the jails, you can see that nowadays we have less than 45% of people getting in jail because of drug-related crimes, when in 1999 there were more than 75%. And finally, we were capable to diminish, also the amount, also the population of people that were using drugs in a very problematic way. So we had more or less like 100,000, people using drugs in a very harmless way in Portugal, especially, people injecting opioids in the public space. And nowadays we are more or less, less than 30,000. So I think here we can see that we have, achieved a considerable and interesting numbers. Nevertheless, I must tell you that use drugs in Portugal is still a crime. We are still an anti-prohibitionist country like everyone else. And what we have, done, I think, better was to change the shift from criminalizing people using drugs when they have more than a specific quantity in their hands. So it's a 10 days average quantity of drugs, for personal use. So that's more or less the limit. If you go above that, you can have a real problem. You can go to the court. If you are under that, normally you go to harm reduction services or to dissuasion commission. Then I can explain a little bit after.
Amazing. And Chibundo, if you'd just like to discuss a little bit more about the Decrim Poverty campaign.
Right, yeah. So as is being alluded to, DC has not passed anything around decrim of substances, whether it's use or distro, any part of that currently. But with our campaign, our first intervention, of course, not the only intervention, is to decriminalize possession. However, even that fight, which was like, this is just our first intervention before the coalition, I would say formally was put together. We already had a moment for decriminalizing paraphernalia during the pandemic, which was really surprisingly easy to do because not a lot of people paying attention because there's a global pandemic happening. But, things are different now. Right now, DC is not a state. Statehood is not certain. That means something really, really significant in the US context, where states' rights is a way how a lot of people are having their decriminalization movement. And right now, Republicans in I would say all parts of government in our federal government are trying to attack home rule, which is DC's ability to govern itself. So depending on how our decrim moment goes for us, even if we just focus on safe consumption now and just making it not illegal rather, and then eventually get to drug decriminalization, our conversation about drug decrim might have to be a federal conversation, even if we're just talking about DC, because DC is going to stay this weird, city state that is the nation's everything. So yeah. I think that what everyone else said about what decriminalization is extremely salient to us still. There's nothing more we have to really add on that. The only thing we really need to add is just our really weird political context due to the fact that we can't govern ourselves, or at least our self-governance is under threat.
So yeah, DC is in a very weird liminal place and has always been throughout its racist history. So there's a bit of a sub-question under this first question, and I'd like to address it to David to speak for Oregon and to Jose to speak for Portugal. So in terms of these models of decriminalization, what was envisioned versus what is playing out, what else is needed, and what metrics are being used to measure success? And David, would you like to take that for Oregon first?
No, I think I would cede that question back to Morgan. She knows way more about this than I did.
Sorry
Yeah.
about
Yeah.
Yeah, so just something I forgot to mention hearing the other panelists is this was passed through a ballot measure in the state of Oregon. If you gather enough signatures, anyone can get pretty much anything on the ballot. And it passed in November of 2020. So it was on the ballot with the presidential election and passed by a huge margin. So the concept, just very simple, is to take personal drug use possession at those low levels, take it out of the criminal legal system, and put it into a health-based approach of social services. The stopping to arrest people was the easiest part, right? That happened like that. February 1st, 2021, police could no longer arrest people for possession, but standing up that alternative system of care in the community was much more challenging. Doing the grant funding, we live in the United States, there's not universal health care. We have very siloed systems of care. So the model was in every single county, there needed to be a behavioral health resource network, BHRN burn. And each of those burns had to be a complete system offering all of the services, in each funded organization having a memorandum of understanding with the other, so that anyone who walks through the door, and you don't have to get a ticket from the cops for drug possession first. Every single Oregonian is entitled to these services at no cost. And they can walk into any of the agencies and get what that agency offers, or if they need, say, housing and they've walked into a harm reduction, trying to refer them around. The money for that system went out about a year ago. So there was a gap between stopping to arrest people and standing up the system. And then we're having a huge behavioral health workforce shortage. So a lot of programs really struggled to get staffed. Now people are staffed. Every organization that took money has to do outreach. So they're going out into encampments and trying to be the conduit for people into services, being that intervention. But it has been incredibly challenging in the American context because utterly lack a system, and we are doing something that has literally never been done before. But it is the largest single investment in behavioral health and substance use in Oregon, and the largest single decrease of the footprint of the criminal legal system. But there are rising amounts of complaints. We'll talk more about this later, but Just recently, multiple ballot measures were introduced to repeal Measure 110 and recriminalize drugs. And so we envisioned a sort of utopia reality, and very unfortunately, fentanyl came. We were one of the last opioid markets in the United States to get fentanyl. It did not come until the supply chain disruptions of COVID, late 2020, early 2021, and it was one of the most rapid transitions from a total heroin market to a total fentanyl market seen anywhere in the US. And so we have seen an increase in overdoses and complications when it comes to things like buprenorphine induction and treatment because of this rapid transition to fentanyl. And simultaneously, the pandemic increased homelessness. And these are all things that we'll talk about later. I think maybe David has some things to say about this later, but it has presented a series of challenges as we are trying to break from the harmful racist status quo of the drug war, which is a war on people, and stand up this brand new system. We have encountered several challenges.
Amazing. Thank you for your thoroughness in answering that question. And Jose, so also to you, what was envisioned in the Portugal model versus what is playing out? What else is needed? And what metrics have been used to measure success?
Okay, yeah. So I think the great envision was, trying to direct or to shift, the regarding from criminal, implication or to criminality, the stigma and criminality associated to drug use to the health approach. And I think on this general, let's say, on this general global view, we have achieved something with that. So with decriminalization, indeed, a new door was opened, to the most vulnerable people that were, suffering from poverty, that were suffering from stigma, that were suffering from police violence, and that because they were using drugs in the public space. So for me, that's quite obvious. I have talked about, the metrics before, so I think I would like to take the time now. So because I talk about outbreaks, HIV outbreaks, and so on. So I would like now to say, that in spite of that, I think that we have two, let's say, theoretical problems here in our decriminalization model. So the first one, is regarding dissuasion. When we talk about the dissuasion commissions in Portugal, that means then, for example, when you're caught in the public space, having a joint or taking any kind of drugs, you can be referral, and most part of the time you're going to be referral for our dissuasion commissions. And that, means that in this dissuasion commission, you're going to be taught, you're going to be, you're going to learn that you need to change your behavior, even though if you're, having no problematic drug use. And I need to underline that. So that means that Portuguese, the Portuguese state still has a paternalistic, approach regarding the non-problematic drug use here in our context. The second one is when you talk about treatment and health. So, or on the other hand, so meaning that when we say that we are opening, the door to the health approach, it means that we are opening the door mostly for treatment. So here in Portugal, we have this problem, of over-medicalization of decriminalization in our context. For example, that means for also that the way we look, to health, it's a very biomedical concept. It's about, the lack of illness. It's about treatment. It's about physical thing. So it means that you're considered to be cured, to be treated when you're not using drugs anymore at all, period. And that brings, me to the next point of our shortfalls here. It's that, about the power that professionals, in particular the medical class, has in Portugal when regards, the treatment or the approach, the health approach to drug users. So they tend to, to concentrate power in their hands. They tend to use, for example, some methadone programs, not all of them, but there is still a tendency to use, methadone programs as a control behavior, tool or as a punitive tool. And that's something that we need also to address in our decriminalization model now and in the future. And the other thing, is the remaining of stigma when we are doing, the medical act. So it's very common so that medical doctors refers or nurses to people using drugs as drug addicts, for example. And that for me, is very clear of stigma being still, remaining on medical approach. And the other one, is using language as an obscure instrument and tool to control also the final decision regarding, the medical act. So there is a lot of, items and variables that we need to address when we talk about, treatment or public health or individual health in Portugal. I would say, and I would, let this for the last question that you have for me, for sure. I would say that we need to replace, this biomedical concept of health for a social or anthropological or community-based, concept. And that will bring us for harm reduction and so on. Thank you.
Yes, and I've often throughout my life as an organizer heard, criminalized people say that between the two systems of criminalization and coercive medicalization, they would actually choose the first, because at least it's more definitive and understandable. So our next question is, but before our next question, I'd just like to say really quickly, there's been some questions from the audience about what the difference between decriminalization and legalization is. I know that we use this language a lot in both, drug policy and sex workers' rights. And I'm going to use a super simple definition. And if any of our panelists during the course of these questions would like to offer more granular definitions, please feel free. Decriminalization is striking drug criminalization laws off the books, whereas legalization is actually legitimizing and regulating previously illicit drug sale and drug possession. So but I'm going to move on to the next question. So what can decriminalization do and what can't decriminalization do? So what I like to say is, like, the day after even an ideal model of state or national decriminalization is implemented, what problems will we be left with? Like, for instance, decrim will not, quote, cure homelessness, inequality, an unregulated global drug supply, and a global drug war. So what are the shortfalls of decriminalization? And Soma, I'd like you to take this first. Soma and Chibundo, I'd like you to take this first as the concepts that you're trying to pitch within your milieu, and then Jose, I'd like you to take it in terms of the Portuguese context. Soma, if you'd like to go first.
Sure, thank you. I feel like we are already starting to touch on the question of what decriminalization cannot do. Decriminalization doesn't solve the mess that capitalism has made. It doesn't solve poverty. It doesn't solve structural violence, although it can contribute to solving structural violence. There's so many things that, we could add to that are part of what we create the vulnerabilities for the people that we're talking about, and like we've said, it's racism, it's classism, it's sexism, it's all of these structural violence perceptions, and it doesn't create an infrastructure like Morgan was talking about in Oregon, how they had to scramble to create this infrastructure. And it's interesting because drug sales and sex work are part of our safety net in the United States. It's a social safety net. Even though it's criminalized, it's a social safety net. So I think, there's the conversation around how we create a safety net to respond to decriminalization. I think, like the infrastructure piece is incredibly important. What I think it does do is it gives us a chance as a society. It gives people a chance. Harm reduction gives people who are incredibly vulnerable, who has been pushed to the margins by tough love and all of the things that we do to push people out of society. Harm reduction gives people a chance. Decriminalization gives us a chance to then build these beautiful build this infrastructure, that is community centered, that Jose was talking about, coming from, like a peer-based perspective and a community-based perspective, and as well as, self-determination. So I think, decriminalization opens the door for people to make choices for their own lives.
I love that, Soma. I've never heard it put that way before, but it's true. In the United States, a country without a real social safety net, Black markets do serve as part of our social safety nets. Shibundo, would you like to take this question next about what decriminalization cannot do?
Yeah. So, like thinking of it most conservatively, it's not going to decarcerate people. We saw that with marijuana decriminalized spaces, that people who are already in jail or prison for certain drug-related charges, specifically around marijuana, were still in jail and or prison. Their records weren't immediately expunged, So like decriminalization rather needs to be like bundled with decarceration, with talks about expungement, all this other stuff, especially as like an automatic process. And also talking about what happens with those folks who, once they are decarcerated, what are their reentry services and where are they supposed to live, going back to the fact that we don't have a social safety net whatsoever, right? I think the other like incredibly like conservative, like not even thinking like liberation wise, dreaming wise, just like very, very literal what it can't do is that it's also not going to, it's going to rather, let's say like cause some issues for certain municipalities who made the drug war part of their community economy. So before I'm in DC currently, but before that I was doing University of Illinois at Urbana-Champaign. I was in some anti-jail building stuff there, some bailout coalition work there. And our county depended on fines and fees, mostly from drug-related incarceration and mostly from Black communities in that area, the Black community in that area. The vast majority of the people who were being arrested and whose fines and fees were taken from them were Black and were in for drug-related charges. That was the money that was keeping our circuit court open. So it's like, oh, so you are literally dependent on people being incarcerated for this, for your government to function. There's no other way for that money. They have no other source for that money. The entire court system would be like just fall apart, right? And that's not just a Central Illinois thing. There are many in the United States. I'm in a big city right now, but most of the United States is smaller areas. And most of these areas, especially like post-Fordist, moment going on there, where the factory used to be the place where everyone got their money, where everyone got their jobs. But when the factory shut down, honestly, county jails supplanted factories as the place where, especially if you didn't get great grades in high school, you go into the army, or if you want to stay alive, you're going to be a CO in a jail, right? So that's also like for small towns, a lot of people, like their whole families are going off of the jail for their living wages. So like we also are not talking about how much the drug war has become a part of like small American economies because it has to a significant degree.
Oh, thank you so much, Chibundo, for putting it in such a grounded materialist context. That's absolutely right. So Jose, in Portugal, what is decriminalization unable to accomplish?
Well, the first thing I would say, decriminalization, of course, was not accomplished to establish a regulated market of drugs. So, and because that's not the aim of the decriminalization. Actually, I could say, that some politicians in Portugal, they are using the success, the exit of decriminalization for stopping, to talk about regulation and of the drug market. So that's quite interesting to see, how, decriminalization can be also a powerful tool to create some, let's say, unprogressive movements, towards a more comprehensive situation. But I would say that, for example, decriminalization in Portugal, because I also want to be positive about decriminalization, otherwise people, will think that it's not working. And there are lots of good things here in Portugal. I would say that it gives us, gives us a moral umbrella. So, for example, it created a more tolerant speech in our decision makers. So it withdraw, the negative charge or values associated to the word drugs. Nowadays, when we talk about drugs and drug use, we don't have, this negative value, this negative dimension, in our media, in our political speech, even in society in general. And at the same time, I think in Portugal, decriminalization, because came with harm reduction, it allows us, to open a new way to look to drug use and to people using drugs in particular. So I would say that people, for the first time in Portugal, with decriminalization and drugs and harm reduction, was seen as citizen for a lot of, of professionals and for society in general. That's for me is quite interesting because the state was obliged to fund in a proper way, in a more or less sustainable way, these harm reduction programs, was obliged to acknowledge the positive impact of this work on the ground. And actually, finally, I think also gave some room, a lot of room actually, for research. So it was possible for our universities and our research to start, to evaluate and trying to understand what was, the quality of this harm reduction strategy and what was, let's say, the added value of decriminalization in general.
Oh, thank you. I really adore that way of describing the multifaceted long-term effect of decriminalization, a moral umbrella. I love that. The second question segues us into the third question, which I'd like to give to David and Morgan. So what is decriminalization blamed for, unjustly blamed for? And what are your strategies for responding to these claims? I think, the backlash in Oregon has been particularly vicious. So I would like to give this particular question to Morgan and David. David, would you like to start us off?
Sure. I wouldn't look at it as what is drug use being blamed for. I think that formulation suggests that there's some sort of argument that's being made. I think the backlash is sort of essentially impressionistic. It's sort of a moral panic built around an allegory of urban disorder, drug use, mental illness, intoxication, homelessness, visible poverty, retail theft, public defecation, things like that. And while rooted in some sort of reality, it's probably better understood as a trauma response by elite members of the society to the dislocation of the present moment. Things like COVID, people abandoning downtowns and working from home, the failures of neoliberalism, the breakdown of traditional hierarchies that social media allows, things like that. But I think at the same time, the panic, the backlash unites the very real interests of a number of normally distinct groups, most notably moderate Democrats and Trump Republicans. So in cities that voted heavily against Trump, this backlash coalition includes African-American Democratic mayors like Eric Adams in New York, or London Breed in San Francisco, or Lori Lightfoot in Chicago. And they're sort of united with downtown business elites, real estate interests, far right-wing police unions, also national sort of right-wing ideologues who want to depict liberal governance as a failure. I see the media as sort of the fulcrum. I think interested parties pitch these narratives to the press, and it's through the press that these narratives gain their prominence. The press repeats the same tropes over and over, and it's through this repetition that the public comes to kind of believe what it believes. It's important to note often the narratives are just completely mythic. They may be, they're sort of maybe based on a few salient but unrepresentative incidents. A lot of times it's sort of like kind of vibe based, I guess I would call it. And facts really don't matter. So for instance, in San Francisco, everybody just knows that under the former district attorney, the reformer Chesa Boudin, that crime skyrocketed. But in reality, police data shows very clearly that both violent crime and property crime went down when Chesa was district attorney. Of course, the fact that it went down didn't prevent him from being removed from office through a removal process that California law allows. But same thing here in Portland. There's been dozens and dozens of stories about the death of Portland in scores of publications around the world. There's been like a dozen pieces in the New York Times alone. And yet there's really no evidence at all that Portland is dying any more than 50 other large cities in America are dying. I mean, Miami, for instance, has lost like 4 times as many people as Portland over the past few years. And as far as I can tell, there have been literally 0 stories about the death of Miami. It's the same thing with like violent crime in New York City. I mean, New York City, they're constant, depictions in the press about violence there, but New York City is one of the safest cities in America in terms of violent crime. It's far more safe than places like Tulsa, Oklahoma, or Wichita, Kansas. But you don't see that in the press. So even though these stories are in some important sense not true or wildly inflated or misleading, these panic narratives, they gain a foothold and then they burn like wildfire. And the press repeats them over and over and over again.
Absolutely. Yes. Thank you. You're absolutely right. It's never a coherent argument. It's a primal shriek, an allegory of moral disorder in the urban landscape, as you say. Thank you for that very trenchant analysis. Morgan, do you have a brief reply to, what decrim is blamed for and how we can respond to those claims?
It's hard to respond to them when, like David said, facts don't matter and the reality doesn't matter. Decrim is variously blamed for just about everything. And I think it's quite interesting because, when I look out my window and I see my neighbors living in tents, I know that the problem is affordable housing. But when they spin these narratives that it's other towns busing people in, or it's drug decriminalization, then the problem isn't affordable housing. It's, that other thing. And so we don't need more affordable housing. We need to recriminalize drugs, or we need to, get these out of towners out of here. And so I just think it's a very convenient way to exert power and control over some of our most marginalized populations who cannot respond. And, one of the most ridiculous things I've heard is that people like moved here because of decriminalization. Like we became a beacon for drug users. And, we did a survey, we talked to 400 active drug users and they were just Oregonians. Like 75% of them were like lifelong Oregonians and the other 25% moved here, which is exactly the same as everybody else. But that is an open question. How do you respond? I mean, I'm over here writing opinion pieces and trying to do media and really push back on those repeated media narratives that are so uncritical and are labeled news when they should be labeled opinion, because it's literally like just a journalist went out and talked to 4 people and it's a series of anecdotes lacking in data. But it's challenging when it's a vibes-based journalism economy.
No, and when we were discussing creating this series about reactionary backlash, we talked about how many hours all of us in drug users union, harm reduction, drug policy movements spend like frantically counter messaging these absurd claims. Takes up so much of our time when, they're not truly evidence-based or based in like the real, lives of the community. So that brings us to the 4th question, actually, which is, so what does need to happen for us to make progress toward a model of decriminalization that is explicitly grounded in social justice, abolitionism, and that doesn't replace criminalization with coercive medicalization? And Shibundo, I'd love for you to start from your, as I know that you've always had like a very strongly abolitionist framework, and then maybe we could have Jose and Soma follow.
Yeah, I believe there's that I think it's from Armed Prisons Obsolete, that Angela Davis quote around how like prisons disappear social problems. So if we use that, I've always thought that was a very helpful like framework for understanding, is this intervention actually just doing this thing? Because we have to be able to witness what criminalization does, which is disappearing social problems, even when it's not in something explicitly called the criminal justice system, or if it doesn't happen in a space with bars, which helps us understand like, other social protectionist, institutions as part of that. I believe that earlier Soma referenced child protection agencies, like they can be part of this carceral system, right? So like, in addition to like forced healthcare, taking people's kids away, is also part of that too. Or like figuring out, instead of talking about like, oh, well, you have a, SUD, you have a disorder, but as such, you cannot have children. And we know, especially like, I grew up as a, young Black kid in the South. My mom was very proud of the fact that she's like, they could drug test me all they want. They can't take my kids away because I don't do drugs. However, we'd also had a lot of fucking issues in our house, right? A lot of the things they were coming for were true. But my mom understood that what the only thing they have against you is whether or not you use drugs. So it's like not even about whether or not the kids are okay. So like I grew up with that understanding that this social protection agency is being wielded as a way to punish people for certain behaviors, right? And we're seeing the same thing with these medical apparatuses that are going to be used as a way to punish people for certain other behaviors. We could learn a lot from, of course, like the CRIP movement there too, about like folks who have been talking about disability, including like mental health, and talking about how medicalization of the social issues that they're talking about that may have medical component, are really used to like minimize people's bodily autonomy and to put them into a social system that we know just won't work, that they'll kind of get stuck in, that can be also very surveillant. So yeah, going back to that original one though, around disappearing social issues, from what we've seen, and of course, like, here in DC, we're also working with drug users and sex workers usually hand in hand. And God bless, knock on wood, we're going to keep it that way because it really helps us keep our eyes open to these things too, where you have diversion courts there, right? Where someone's like, okay, we arrested you for being a sex worker. So instead of perhaps, taking your kids away and putting you in prison, we're going to put you into this diversion program. And it's like, well, what are the ends of that program? Just because it literally was not criminalization and the very literal concept that we are thinking of does not mean that's what the experience was for other people. So I'd say my answer to that is definitely staying with the people with the lived experience, because one, they've probably already gone through a lot of weird ass systems around, diversion, which can be put in quotes because that's a really weird concept depending on where you're at, especially if you're like a person who's been a lot of places. I was going to say transient, but really cosmopolitan, where you understand the carceral system in a lot of different places. You understand what suggestions will work and will not work and how this will actually affect people. Those folks are the most important, especially those who grew up, in a space where lived experience was something, whether or not they had it from a very young age, they were around it from a very young age. If they had a parent who was using substances and was like, targeted by these systems, like keeping with those people, they have the clearest perspective, the clearest lens to see where a certain suggested intervention will end. And they don't need to study it. They already have that effective, like immediate visceral understanding, like that's fucking bullshit, you don't have to listen to that, rather than like, okay, let's try it out and put a study, like to make a bill for a study that'll take 3 years, and after that study starts, it'll take 5 years to like look at that data, and then 20 years later we'll say like that intervention was never going to work, apparently, who knew? So
Thank you for that common sense answer and for that shout out to Our Prisons Obsolete. I wish we could just give everybody in all of our adjacent movements a copy of that book. I believe that, let's see, I believe that maybe Soma was next on what needs to happen for us to progress towards a model of decrim that's explicitly grounded in social justice and abolitionism and doesn't replace criminalization with coercive medicalization. So Soma, yeah, would you like to tackle that one?
Yeah, I think it's interesting to talk about the war on drugs being present in systems of care. And there's a few people on the panel who have referenced that, so the structural violence piece, confronting the structural violence piece, I think is so incredibly important. There's a woman named Joanna Shapiro who's wrote a lot about violence in medicine and structural violence. I'm going to read you, sorry, I'm going to do this. Sorry to throw a quote at you, but I'm going to do it. So I'm going to read you a little bit of her work. She says, the existence of structural violence makes it easier for privileged physicians to see themselves as distinct and separate from their patients. So think in terms of there's physicians, but there's also social workers. And then, maybe even think of society as whole. We see ourselves as separate from drug users or sex workers. So rather than implicated in the institutions they serve and the jobs they benefit from, when illness is perceived through an exclusively biomedical molecular lens, it is unlikely physicians will emphasize the social determinants of illness. These limit our perspective often, these limited perspective often result in physicians seeing under-resourced patients as responsible for their own problems, not caring about their own health, or not choosing health as the highest priority. Structural violence results in harm to patients both directly through disadvantaging them in terms of health and access to healthcare, and indirectly by allowing physicians to adopt simplistic patient blaming attitudes. And I think that sort of the war on drugs and DEA can be very present in these medical systems. Like talking about, building the new infrastructure that works, we really have to address stigma within our social services and, come and get physicians and, people who have power to adopt and understand community-based, peer-based solutions. And then we have to address this, I think, in society as a whole. And we've got to get into places, where the NIMBYs are and where they're, I think David was talking about, like the panic narratives and then like the kind of trauma response to disorder in society. So some people are actually really, really traumatized in society, and they don't understand some of these complex issues that are contributing to their neighborhoods, being a mess, right? So we need to get into neighborhood councils and start talking to people. I can't believe I'm actually saying this. This is like, it's crazy, but I think we need to take a little bit of a playbook out of from Trump's playbook of, infiltrating. So we have to have our people, the way that Trump put a bunch of white supremacists in small roles throughout the country in the US, we have to do the same thing. We need to be in positions of power, and we need drug users and sex workers to be in positions of power. And I think as a harm reduction movement, we need to expect more as well. So I'll hear drug users who are, like myself included, newer to harm reduction saying, I just need to get paid for my work, Yeah, you need to get paid for your work, but you really need to be centered. You are an impacted person, so we really have to kind of build power, I think, and lift up the people who really deeply understand. And I know I'm talking a lot, so I'll just stop there. But I think we need to dig in and get our people into places where they can persuade and change the narrative.
No, and I really appreciate that similarly pragmatic answer. I particularly appreciate what you were saying about, how much different organizations led by directly impacted people are focusing on designing trainings for medical professionals right now, because I always reference that moment where in my local organization of low income and survival sex workers who use drugs, we realized that most of us feared the local hospitals even more than we feared the cops. So Jose, what would you like to say about what needs to happen for us to progress towards a decriminalization model that's grounded in social justice and abolitionism, and that isn't just replacing the old model of criminalization with coercive medicalization? And you've spoken a lot already about coercive medicalization, so I'd love to hear a little bit more about that.
Yeah, okay, so thank you. And so as I said before, and following what Soma was saying now, I think that we need to address a new concept of health. And so that's the first thing, let's say, the theoretical approach, and saying that we need to address, well-being instead of illness, or of being healed or not, or being healed or not healed. So my thing, is that we need to go for a biopsychosocial approach, where you can look, to the person that is using a particular, or a certain person, or a singular person is using a particular drug in a particular context. And that means a lot, that means that you cannot uniformize, you cannot, standardize, the way you look to people, the way they take drugs, and you cannot put, under the same notion, the word drug. So there's a lot of different types of drugs, as we know. There's a lot of different amounts of, of drugs that you can use. There's a lot of ways of using drugs, and there are lots of contexts, supportive or not supportive, when you're taking the drugs. So I think that's one of the things I look at, to the well-being concept and not to the health concept in a very restricted way. I would say that with that, we need to go deep in harm reduction programs and strategy, meaning, for example, that we need to address housing, strategies, housing first strategies, as people were saying here. We need to address stigma. We need to address training, education for everyone, even for journalists, for the priests, for neighbors, as Soma was saying, for the users, of course. Above all, for people using drugs, they also need training, also need empowering, they also need, access to education. We need access to job market. We need, to promote a more flexible, tolerant, and let's say, open social reinsertion strategies. So we need, you really need to implement, social reinsertion strategies where people, can have access for the first time, or after a long decades of not being working, can be, access in a very protective way to the job market. So that's very important, that people can start to gain money once again with a proper wage or salary. For example, we need to address and underline the importance of peer work and peer education, on harm reduction programs. So I think we need to also to fight for that, and we need to consider people that that have this kind of experience, this kind of skills, at the same level that those ones that are considered to be the professionals with the technocratic knowledge. So the living experience need to be valued in our programs, in our health approach or harm reduction approach. So, as someone was saying, I will underline not health, but the health social determinants. I think that's one of the keys for that. And also I would say that we need, for example, when we talk about peer involvement, when we are designing new programs, new strategies, we need to involve peers and people using drugs since the beginning, since the needs assessment, since, the conceptualization of the program, in the implementation of the program, and then in the evaluation of the program. And we need to pay them for that. Some years ago, in our organization, we were doing that. Now we are not doing that anymore. And we need to know why we are, not doing that anymore. And we want to come back to this kind of approach. So we want to involve people since the beginning of a new strategy implementation. And we want them to evaluate, the clients should evaluate, and and we should put the focus on that. And finally, I want to address, as some were saying, people before, that, of course, we need to have more and more, harm reduction service peer-based or community-based. For me, that's completely, clear. And finally, one thing that for me, is more, and so that was, I think, the end of the speech of Soma. And for me, it's one of the most important things. That's, one of the things that we have learned in Portugal, but in Europe, around Europe, is that we need to talk with our opponents, the so-called enemies. So we need to address them, and we need to respect something. We need to respect that they have fear, that they are fearing something, that they are angered, with this drug phenomenon new approach. And we need to give them room so that they can express their feelings, they can express their emotions, they can release their fear. And then we could come back, we should accept that. And then we could come back with some evidence dialogue based, but I think that emotions, primitive emotions, primitive feelings, they are blocking, the dialogue between us and them. And we need to create a kind of new door, a free communication channel where we can be seated at the same table, and express our prejudge, our emotions, and so on and so on. Sorry.
No, and I think what you just said really echoes what David was saying earlier, this sort of primal fear and anger driven sort of nightmare vision of the urban landscape. And so I really respect what you're saying about giving room for that so then we can address it. I also love how everybody on this roundtable is so down to earth and materialist in their analysis, and how everyone is unanimously recommending a drug user and sex worker led politic. I love that. I am going to move to the next question, which is, so amidst all of this reactionary and sometimes neoliberal backlash, what can we do to safeguard the advancements we've already made in decrim? What can we do to keep these policies in place and support these efforts elsewhere amidst this conservative backlash? And I'm going to go to David first and then Morgan.
Yeah, well, I mean, I think, so long as the panic backlash is the sort of background music of the culture, it's going to be very hard to make progress, because it is at root a panic. It's not really amenable to evidence or social science or rational argument, at least not initially. And it's not an earnest description of the problem, and it's not particularly interested in a solution. So I think it's a challenge for people who think of themselves as progressive, who sort of naively demand that contests over policies, be waged in the mode of science and reason. So I think one of our first tasks has to be to tamp down the volume of the backlash. So we need to interrupt the panic narratives immediately. Like once they take hold, they just start to burn like wildfire. And so we can't allow them to take hold. When the end of Portland narrative appears, it can't be a year or 2 years before people are responding. Another thing is, I don't think we should assume that the factual bases of the narratives are true. A lot of times, it turns out that underneath this, the data shows something very different from what the press is saying. And so, that needs to be contested, every inch of it. I think we need to use social media to embarrass the press when they write stuff that's wrong and evidenceless. I spend a lot of my time doing this, even though it's really not very much fun. Make them pay a cost, name the journalist, shame the reporters, shame their editors. Don't stage a protest in some public plaza, stage it outside the newspaper's office, stage it outside their publisher's home. The press is, at least in theory, supposed to be a sort of evidence-based profession. And so I think that's a place where it really needs to be, kind of confronted and interrupted. I think we need to offer competing symbolic narratives. People are angry and want to blame someone. Well, who is to blame? Are real estate interests to blame? Are NIMBYs to blame? Are the heartlessness of our political leaders to blame? I think also, compete on the realm of moral values. We need to say who we are, and not just that like what we want works, but that we need to offer a competing moral vision that includes all humans, in our analysis. I think we need to recognize that people aren't really angry about drug use. They're angry about, kind of public nuisance and disorder or whatever. And so to some degree, to the extent that we can, address the nuisance. There needs to be public bathrooms and needle pickups and campsites and things like that. Don't try to convince everyone. I think that's another thing that progressives do that's incredibly stupid. Our job is not to convince every last person. Our job is to convince the people who are convincible. And take advantage of political power. When we have the political power to do things, do it. We're not engaged in some sort of like constantly building movement towards progress and enlightenment. Instead, it's a street fight. And when you have the opportunity to enact or the policies that you want to enact, do it. And I guess just finally, I would say recognize that what we're up against is a panic. We're not going to win it with a calculator. It's a street fight. And so, engage the street fight.
I love that very realistic understanding of where we are in this discourse, in this discursive battle, rather. So yeah, let's see, Morgan, would you like to take a stab at what can we do to safeguard the advancements we've made, and what can we do to keep policies in place and support these efforts elsewhere amidst all this backlash?
Yeah, I'm also going to answer this question from Jess. A lot of the panic that I'm seeing, at least, is focused around fentanyl. And I got some pushback sometimes when I was talking about this as a moral panic. And the important thing here is like our target demographic, they're actually pretty swayable. It's like moderate Democrats. These are, at least in Portland, it is people who voted for Joe Biden and also voted yes on Measure 110 in November 2020, but now have just seen these very shallow media reports, which have given them an outlet for their frustration because there are legitimate social ills visible walking down the street in our city. And it's given them a very convenient scapegoat. So now they're against it and now they're voting. And so that's our target demographic. And fentanyl has played a large role in this panic. And it's challenging because there is a lot of harm being produced. Usually when we talk about moral panics, they're things that like literally don't exist. This is like people spinning their wheels about things that are not real. And fentanyl is a little different because it's an actual harm, but where people think that harm is occurring is totally wrong. And so it's taken on all of the features of a moral panic while actually having a body count attached to it. And so there was an effort to recriminalize fentanyl in the past legislature, and it was very narrowly defeated. And they dropped the threshold down from 5 grams to 1 gram. And that is now, the underpinning of a lot of the recriminalization movement. Well, when Measure 110 passed, Oregon had heroin. And now that you have fentanyl, it's an entirely different landscape. None of the previous rules apply. Well, yes, sure, the drug war failed with heroin, but fentanyl is totally different. So the strategies that failed forever, for decades, for those other drugs are definitely going to work now because fentanyl is different. And it's all just so preposterous. But when I sit down I sat down to get my hair cut, the lady was, you hear about this? They were going to give the junkies tinfoil to smoke their fentanyl. And I was like, oh, I did hear about the safer smoking initiative from the county. Do you want me to tell you why? And then she just listened to me for a few minutes. And then she stopped and she said, why didn't they write that in the news? And I actually got through to her. So these people are not necessarily deeply entrenched. For specifically, Measure 110, this is an all hands on deck moment. We have recriminalization coming to the ballot. Apparently, just about anybody can publish an op-ed on Measure 110. Anybody can call themselves an expert from anywhere else in the country and publish an op-ed about Measure 110. You don't necessarily even have to come here. Or you do. You can just walk around for 6 hours and then call yourself an expert on Oregon. So I would just encourage people to, do that. We need more academic literature. We need more opposing narratives. But if it's a vibes-based thing, okay, let's bring our vibes. We don't need to bring out the calculator and but the facts and the statistics. No, because we also have vibes. This is not a theoretical discussion. We're not talking about decriminalization and what might happen. Nobody knows. No, we have 49 other states to look around. This is what happens when you criminalize drug possession. The harms it produces are real and tangible. And so leaning into that vibes and just talking about the true harms of criminalization and where we're trying to go. And so, I personally am writing opinion pieces, I'm contributing to academic research, and I'm just talking to people around me. And I have found it to be actually pretty fruitful, that people just need a little help to reinterpret the things they've been reading and seeing to come back around.
So I think this is a great time to move toward the question and answer period. Luckily, Morgan, you just answered one of our attendees' questions on the efforts to recriminalize fentanyl. And I know that Morgan actually did an incredible presentation on this at the Contemporary Drug Problems Conference not too long ago. So be sure to follow her work on this if you're interested in more. Kate Roberts asks, and I think anybody in the panel can take this question. So how do you see substance use disorder treatment models complicit in maintaining drug criminalization in the US? Oh, it is a US specific question. So anyone here from the US want to take that?
I'll just say one part. And again, this extends over to sex workers too, where you see when it changes from a criminal issue to a safety issue or a health issue, police become social workers and jail becomes a social service. And the difference between treatment and jail starts looking all really weird, because at least in the places I've been, people start saying yeah, people need treatment. And if they're already in jail, jails need to become treatment centers. And it's oh shit, that's crazy. That was a really wild way to get there. But yeah, the carceral apparatus, at least what I haven't witnessed, and a lot of people even here in DC who are excited about talking about safe consumption or decrim, in no way are they seeing that and then the corresponding action is that our carceral infrastructure will somehow shrink. They're just like, no, the carceral infrastructure will be repurposed. We need more trainings for police. We need to get naloxone for police. We've already, we've witnessed some terrible things, like cops going around naloxoning people just to be dickheads. Same with our sex worker stuff. Cops knowing a girl has been here for years, but going around and saying, I need to question you and make sure you're not being trafficked and all this other stuff, like using it to do the same bullshit, right? Get them into the same systems, have the same amount of like just lack of safety that they feel everywhere else. And not to go to full Foucault, but we're going to see the hospital become a prison, right? The hospital will be the prison. And then also hospital workers and health workers in general will become part of the carceral apparatus. What's their reporting going to look like? What's it going to look like when people know that in order to, well, this isn't happening anywhere, and I almost want to knock on wood because I don't want it to happen, but like if someone's like, I want to access services for some reason, and someone's like, I am now a mandated reporter, not just for trafficking, but now for certain types of substance use or using substances in certain places, or you told me a story where this happened, XYZ, and then everyone becomes a fucking cop. So that's what I see happening with that.
I mean, I think you should go full Foucault all the way. I think biopolitics and the panopticon are still very relevant concepts when we talk about medical complicity with criminalization and coercive medicalization today. So feel free to go as Foucault as you like. Does anybody else want to answer that question about how we see SUD treatment models complicit in maintaining drug criminalization in the US?
Yeah, sorry, Morgan. I've just got a couple things. I'll pass it to you real quick. I mean, I think something that we need to continue to talk about is how after rehabilitation, drug treatment, sober living, that's when people are most vulnerable to overdose. And what we see in treatment settings is there's the harm reduction model is so often not adopted. So there's many places where you can go for treatment and they're going to say that you can't have Narcan there, which that's setting people up to die, I think part of this is sort of redefining what recovery means. And I'll speak to that briefly personally. So I have 7 years of recovery. I do not have 7 years of sobriety. More recently, I just started using cannabis again. And I'm also using ketamine as needed as part of my mental health treatment. But from an AA or 12-step perspective or the abstinence-based perspective, I'm no longer sober. I'm no longer in recovery, right? So I think it's very important for us to redefine what recovery actually means. And again, like talking, sort of ringing the same bell again, recovery needs to be self-determined. And, like Chibundo is talking about, the mandated reporter thing is really interesting because there's also this perception that you need to report everything. Mandated reporter does not mean that you need to report drug use or sex work. Mandated reporter is someone going to die? Is there an elderly person or a youth who is in danger? And that's pretty much it. So like this whole idea of like, well, let's call the human trafficking line, say something, say something, we have to take, and again, kind of referencing what Chibundo is talking about is take the cop out of healthcare, take the cop out of treatment. Sorry, Morgan, I'll pass it back.
Beautiful answer. Thank you so much. The disease model of addiction has been completely co-opted to now uphold and support models of criminalization. I saw this in the Measure 110 debate we had with some elected officials and experts, where they said, well, these people on the street have the disease of addiction. And remember, when this was first released, it was like a progressive notion at the time. It's not a moral failing, it's a disease. But now it's these people have a disease. So they are therefore incapable of making choices and must be coerced. So we are going to be the benevolent, compassionate arm of the state and come in and intervene on these poor, sick, diseased people. And then I have seen our SUD leadership actually support and endorse this model. And so there's this very nefarious alliance between carceral punitive actors and SUD treatment who are laying into the disease model. And it absolutely breaks my heart. They're completely discounting the agency and autonomy of drug users. And yet it is one of these other convenient narratives that semi-well-intentioned people, but that are ill-informed or have very superficial understanding hear and go, oh yeah, that makes sense. Let's go with that. And so I definitely do think that this becomes a very toxic feedback loop.
Yeah, it's interesting how when medicalization and criminalization work in concert, the drug user becomes both sick and bad. We both have no agency, and yet we are also to be punished for the consequences of our actions. And I also wanted to say back to Chibundo's point that, I think that this whole cops as social workers and cops as social services discourse is being utilized now because they're finally flailing for relevance at a time when police abolitionism is becoming a more mainstream discourse. Please go ahead, Shibundo.
Oh, that wasn't to interrupt. I was just putting a hand up to make sure that this one last point is that, again, it's learning from disability justice folks, especially people who talk about like the concept of madness and what that looks like. Detainment is, you don't get sentenced to being detained if you have a certain like illness. You are ill until someone says you're not. And sometimes they don't say you're not, like ever. There's no time you're not, there's no rules that you could play or be like, I'm gonna get a lawyer, da da da. No. The lack of rights that people with certain disabilities have, that people that are seen as mad or sick have in this system, is terrifying. It's completely horrific. So like, this is also a great place where we can work with people who have been talking about this for ages. The shutting down of the asylums, especially in like the 60s, 70s. You have your Rosemary Kennedy moments, right? You have all these moments in American history of other people who have been disappeared and people who have been forgotten when they were put behind these doors for treatment. So I just wanted to bring that up too, is that like, if we have cops being the people who could decide when people are well or not, I'm just saying. And also like, who's gonna say then like if a cop has like a justified, what does justification look like then too? If someone's crazy or someone's sick, what then is not a good intervention for a police officer to forcefully make them better?
And thank you so much for making that point. I think that's integral. Earlier I said that I've had discussions with criminalized people about what they prefer, to be to be involuntarily hospitalized or to be put in jail or prison. And many people have said that they prefer the latter. And it was in the MAD movement that I had those conversations, in the consumer patient survivor movement, to protect the rights of those diagnosed with psychiatric illnesses. And so I think, it's really time for drug user and sex worker movements to really join with disability justice and MAD movement discourses and campaigns, because we're all fighting the same war in which people are pathologized and, seen as less than and dehumanized. And then systems are created to process those who are categorized as subhuman. And yeah, there's one more question. It's more of a comment than a question, but perhaps it can just lead us into whatever anybody wants their final words to be. The venerable T. Stephen Jones says, "This is a wonderful webinar, clearly showing that, quote, decrim is not enough, not sufficient, that we need so many changes in the support for people who use drugs, a safety net, sex workers needing access to healthcare, ending stigma, et cetera, et cetera. Even so, decrim is worth pursuing, right?" And now I'm not sure whether that's a rhetorical question, but if anybody has any final thoughts, perhaps we can end on that question.
Yeah, I can just, decrim is necessary, but not sufficient. It is, as someone who was heavily criminalized for my substance use, forcibly stripped off of my buprenorphine and forced to detox in the county jail, I assure you that under Measure 110, Oregonians are suffering less. And to the stigma point, we often talk about stigma as if it were this nebulous thing that comes from, I don't know, in interpersonal relationships. But criminalizing drug possession or criminalizing anything is literally producing stigma. You are saying this person who engages in this behavior is a criminal, is a bad person. And that is a physical manifestation of stigma that therefore further reinforces stigma as other people say, criminal, and then it becomes another feedback loop with stigma. So I don't think stigma is as nebulous or mysterious as we make it out to be. It is a direct result of criminalization. So therefore, decriminalization is a step forward to diminishing stigma among drug users.
Does anybody else want to have their last words along those lines? Anyone step up?
Can I? No,
Please go ahead. Yes, we haven't heard from you in a while.
Okay, yeah. So I was thinking about some kind of concerns that we have here in Portugal. At least I have in my team, the team I work with. So about one is about the transfers of this learning to the next generation, to the coming generation. So what does the new people know about this? And I think that there is a lot of lack of information on the youngest ones about decriminalization, about the problematic of drug use, the things that we have achieved in spite of what. And one of the things that we are addressing and trying to fight for is somehow this decriminalization of harm reduction, for example, lessons in the university. So we want the academy to implement harm reduction as a kind of discipline that you can and you should taught or teach in the university. That's one of the things. The other one is invisibility. So there is still a huge invisibility, about the people that are using and suffering, from using drugs in a problematic way or in a problematic context. And so they are only, being reclaimed for the public space when it's, to talk about the so-called moral, panic and to criminalize them. So we only give them, a stage when we want, to criminalize and we want to point the finger to them. But we don't see, these invisible people and communities in their daily life. So, situation. And I think that's something that we also want to address, with trying to build more and more, upon, personal narratives and so on. So trying to show what is it, to live with drugs, or to live, to be a sex worker and things like that. So trying to normalize, let's say it, or trying to give a kind of, image, positive image of these people. And there was a final one. The final one, is, I think maybe you have done already a debate on that, is about pleasure. And so we are a society more and more, based in an economy of pleasure. And of course, we need to accept, we need to address that people are also using drugs because of pleasure that they take with them. And there's something that we never address on our narratives, on our dialogues. And that's something that we are, there was a kind of movement in Portugal trying to address that. And now we are a little bit, let's say, stuck on this, but we want to move forward on this agenda of pleasure also.
What I really love about the way you've spoken the whole time, Jose, is you're so holistic in your view of drug use. One of the problems of criminalization, medicalization, all of these models, not only does it violate our human rights and harms us, it's so incredibly just reductive, just stupidly reductive about a human behavior that's been going on for as long as civilization as we know it. So does anyone else have, we have time for one more person to have a last minute word if they want it, if anybody else wants to address anything else before we close out?
Just a little bit. To that point about pleasure, I think that the current moment where we're all talking about bodily autonomy, especially after Roe versus Wade was overturned in the United States, is a huge opportunity for a lot of us to kind of come together and, finally see some common ground here. It's what other, behaviors are being criminalized in the United States, and what work is it doing for what groups? So I'm very much, all about how pleasure needs to be part of discussions about bodily autonomy, rather than just talking about someone's life or death choices. But going back to also what you were saying, Jose, about like personal narratives, right now, people with lived experience can't really share their personal narratives without incriminating themselves in a way that can affect like their entire futures forever and always. So I'd love for that to end with, and decriminalization will help with that. Also with what we're talking about, having people with lived experience working on these issues, lived experience needs to become a credential. Like that's something I've been really excited about. I'm from the university and I'm like, you need to have like someone having a criminal record should be a credential for them to actually talk about how this is going to interact with the healthcare system, or how to make sure that the healthcare system doesn't become a prison. Like someone having like even some ways that we still stigmatize very greatly. I'm going back to the whole like child protection thing, because just that was again a lot of my what would I say, like being radicalized into like thinking of this critically was just my own relationships with DCFS or CPS or whatever you want to talk about, call that. But yeah, like even there where it's just like someone having an experience with that system, rather than being like they are, especially for like women and femme people, now no longer able to speak about that, because there are plenty of things that people are not allowed to speak about, even when it comes to like within substance use spaces. Losing your kid is definitely fucking one of them, and those people have seen some shit. When we think about other organizations like Black and Pink, Survived and Punished, that specifically talk about like I think get us at the masculinization of abolition, how like masculine and focused it is, where we're talking about drugs as a thing that happened to like, this idea of what would I say, like an ethnic man, that a general ethnic man we have in our head, or maybe like a white person who's from a certain community, like a low income community, but it's usually not a woman, it's usually not a trans person, it's not usually a parent, so on and so forth. So, sorry, go for it, Katie.
No, I mean, and even though people identified by the prison system as women have climbed in the prison population by 400% since the 90s, and are still the fastest growing prison population. And that's also why we at, North Carolina Survivors Union, one of the affiliate groups of National Survivors Union, in our narco-feminism story share, we use the concept of reproductive harm reduction to talk about the reproductive needs of AFAB people and women and non-binary people and trans men. And, just like how harm reduction wasn't really addressing the needs of pregnant and parenting people who use drugs, and neither was reproductive justice. So we need to create a whole new theoretical framework. Anyways, I just want to conclude by thanking all of our panelists today. This session will be appearing on our new YouTube channel site that I think Becca just linked again in the chat. Thank you so much. This has been such a brilliant and revelatory conversation, and I feel honored and privileged to have been able to join you all. Thank you so much.